Okay, so let's start. Good morning, everybody. So we are continuing in discussing different glomerular diseases, and now we are discussing diseases which cause significant proteinuria, which constitutes the nephrotic syndrome. So I'd like one of the undergrads to unmute and tell me what are the components of the nephrotic syndrome. You've heard this many times now.
Nephrotic range proteinuria, hypoalbuminemia, lipidemia, and lipiduria.
Yes, and what is the extent of proteinuria? What's the cutoff?
Greater than 3.5 gram per 24 hour and albumin greater than 2.5 gram per 24 hour.
Less than. Albumin, serum albumin less than 2.5.
No, I meant albumin in the urine. Yes, serum albumin less. Albumin in the urine is also greater than 2.5, right?
So we can't really, when we estimate the proteinuria, it is albumin only which we are estimating most based on the techniques. So the 2.5 number is for serum albumin. So just recheck where you've read from. Okay. You're absolutely right. So you need more than 3.5 grams of protein to come out in 24 hours. When you're losing so much protein, you will have hypoalbuminemia, you will have edema. So those three things need to come in together. And then you have hyperlipidemia and lipiduria. Okay. So we're going to revisit some concepts as we understand the glomerulus a little in a little more detail again, because we understand that the glomerulus is responsible for keeping all the proteins in. And therefore, when there is glomerular pathology, there is going to be some proteinuria. And all the diseases that you've heard about till now, they all have some amount of proteinuria, even if it's part of a nephritic syndrome. So what is so special about nephrotic syndrome? What is the hit to the glomeruli which results in such massive protein loss, which results in the nephrotic syndrome? So this is the scanning electron microscopic image of what a glomerulus looks like. So scanning EM is a surface visualization, and you can see the glomerular capillary loops, and you can see how the visceral epithelial cells or the podocytes are sending their processes down, and that's the cell body of the podocyte right there. It's sending processes down, primary, secondary, tertiary, they're interdigitating, and they're really investing the external surface of the glomerular capillaries. Let's look at it in more closer up. Again, that's the body of the visceral epithelial cell. And then you have primary processes, secondary, tertiary. Look at how they're interdigitating, right? And this pictorial basically shows you what's happening. So if you look at it, if you look at the two interdigitating foot processes, you'll see that there'd be slit pores between them, right? We've seen that before. But you can see that as they interdigitate, it could be that on one side of the slit pore, the podocyte is from this visceral epithelial cell, whereas from the other side, it's from this visceral epithelial cell. Okay, so that's the extent of interdigitation that happens. And therefore, you'll see that when there is podocyte injury, there's a lot of propagation of injury. So if there's a problem with this podocyte, there'll be propagation of injury to this podocyte. And that is how it would propagate in the glomerulus. So let's take now a more of a 2D view, that if we took a single glomerular loop, and we've seen this image before again, what do we see? This is the stalk, this is the mesangial cell, this is the mesangial matrix. So pay attention to what it looks like here, because when we show you transmission electron microscopy images, this is how we identify the cells. A mesangial cell is identified as a nucleus with some cytoplasm embedded in matrix. That's how we'll identify it. Then you have the endothelial cell here, and the visceral epithelial cell or the podocyte on the outer side. Okay. So again, what is the filtration barrier? This is repetition. You've got the internal endothelial cell layer with fenestra, which are around 70 to 100 nanometers. You have a 3-layered GBM, which is composed of the laminar area interna, the densa, and then the laminar area externa. And then you've got the visceral epithelial cells, and you've got these podocytes. And between them, there would be slit pores, which have a much smaller opening of approximately 20 to 30 nanometers. So the structure of the glomerular filter or the filtration barrier is therefore composed of these 3 layers, which form a size and charge-dependent barrier function. So let's see in real-time transmission electron microscopy imaging. We've seen this before as well. and we see the 3 layers very clearly. This is the endothelial side. So this would basically be plasma, giving this granular sort of appearance. Then you have the GBM, 3 layers, and then you've got the podocytes. Okay, so this is from a normal glomerulus. And if you would zoom in at extremely high powers, you may actually see a slit pore right there. And you can see all the 3 layers of the filtration barrier. And like I mentioned, it's size and charge dependent barrier function. Now, in this whole filtration barrier, the 3 layers of the filtration barrier, the podocyte, which we've seen on a scanning electron microscope and transmission electron microscopy, plays a pivotal role. It is absolutely pivotal in maintaining this filtration barrier because it provides this last line of defense by forming this slit pore. Okay. Now, other than that, the podocyte also has other maintenance functions in the glomerulus because it's responsible for synthesizing GBM components, as well as it maintains the health of the endothelial cells because it produces VEGF. Okay, so VEGF is vascular endothelial growth factor. So you see that this is one of the most important cells in the glomerulus. And what does this slit pore actually contain? It is composed of 2 very, very important proteins, which we're going to be talking about in details. One is nephrin, and you'll see that there'll be nephrin from both sides of these foot processes. And then you've got podosin, and then you've got other proteins which connect the slit diaphragm proteins to the internal mechanism of the podocytes, which includes CD2AP, alpha-actinin 4, and then it all connects it to the actin cytoskeleton. Okay. All these proteins are very, very important for the health of the podocyte. The slit pore, of course, we know what its function is, but all these internal proteins are also important to keep the podocytes nice and upright, keep them intact so that the slit pores can remain intact and that filtration happens well. Okay. Now, the other interesting thing about the podocyte is that they are terminally differentiated epithelial cells. So they basically are originating from mesenchyme, and they undergo what we call a mesenchymal epithelial transformation and become epithelial. Okay, and they're terminally differentiated epithelial cells. Of course, when you injure these cells, different things can happen, and we'll see what happens when there is podocyte injury. So here I'd like to introduce a concept which is of podocytopathy. Okay, so what this is self-explanatory. It's an injury process or a disease which is affecting the podocytes. And what we understand is that because the podocytes are so important in maintaining that filtration barrier, that if you have something which is really injuring the podocytes, you are going to get significant proteinuria. And this is most likely going to be nephrotic range or nephrotic syndrome. Okay, that's the first concept. The second concept here is that the injury to podocytes could be primary or secondary. So we're going to look at different situations which can injure the podocytes, and we're going to correlate them with the usual histologies or pathologies that we talk about in the kidney. Okay, but this podocytopathy concept is very important in understanding proteinuric kidney disease. So first, let's look at primary podocytopathies. What do I mean when I say primary? I mean that there's nothing else wrong with the glomeruli. This patient is not a case of lupus nephritis with some proteinuria. This is not a patient of diabetic nephropathy with some proteinuria. I am talking about those diseases of the glomeruli where there is nothing else happening except a direct podocyte injury. Okay, so that's what I mean by a primary podocytopathy. Now, if you look at this slide, you'll see that the podocyte injury can happen in 3 ways. If the injury to the podocytes just causes damage to the podocytes, like you can see over here on this right pictorial, I don't know if you can make out, but they're effaced. It's just fallen flat. Okay, so there's injury to the podocytes causing podocyte effacement, but no reduction in podocyte number, which means that there was no cell death, no loss of podocytes. This is what is associated with minimal change morphology on histology. Okay, we've seen minimal change disease. We know that minimal change disease is the most common cause of nephrotic syndrome in children. we know that around 90% of these children without a biopsy will receive steroids and they'll be fine. They'll respond to steroids and the podocytes will become healthy again. Okay. So this sort of reversible injury to the podocytes, causing them to fall flat but not fall off, is what associates with the minimal change histology. Now, you could have a podocyte injury, which potentially could be more severe, or it could be a different type of podocyte injury, which causes podocyte detachment or death. Podocytes are now falling off. You know that this is now an irreversible sort of podocyte injury. When those podocytes fall off, it induces segmental sclerosis, and I'll show you how. That it results in the entity which is known as focal segmental glomerulosclerosis, or FSGS. Okay. And from the clinical discussion yesterday, we understand that both of these types of histologies can be present in patients of nephrotic syndrome. And it is the FSGS histology which correlates more with steroid resistance. They don't respond so well to steroids, and you need to go to second line immunosuppressants to deal with this disease. Now, the third type of podocytic injury is a podocyte proliferation. Okay. Now, if this podocyte proliferation is associated with this look of mesangial sclerosis, and it's a low-level podocyte proliferation, like you can see here, it results in a morphology called diffuse mesangial sclerosis. If podocyte proliferation is very, very high, so much so that the epithelial proliferation just collapses the underlying tuft, this results in the morphology which is called collapsing glomerulopathy. Okay. So these four morphologies are associated with primary podocytopathies. Again, by which I mean that there's nothing else happening in the glomeruli except this. But they are also associated, these injury patterns may also be seen in other conditions with secondary hits, and we'll talk about that. Okay. What happens to these podocytes to cause them to proliferate like this? That's an important concept, considering that we've just said that podocytes are terminally differentiated epithelial cells, right? So in the collapsing glomerulopathy pattern, what that means is the injury to the podocytes has caused it to re-enter the cell cycle. Okay, so there is a de-differentiation and they re-enter the cell cycle, which allows them to become so hyperplastic and cause capillary loop collapse. Okay. Right, so let's move on. So this was the concept that I wanted to introduce of podocytopathy, of how we really look at these diseases now. This is a concept which is maybe only a decade old, because before that, all we did was call things minimal change FSGS. We were not really thinking of what these patients had or what kind of podocyte injury they would have. But let's look at what we see on histology. Minimal change, as the name suggests, glomeruli are going to look nearly absolutely normal. That's a normal glomerulus. Let's check every part. Capillary loops seem pliable. There is no significant mesangial hypercellularity. There's definitely no endocapillary hypercellularity. And we will point out one cell there. Yes, who can unmute and tell me what is this cell at the arrow? Can you see? You may have to zoom into your screens. Yes, Swapnil, can you say that again?
Podocyte.
Podocyte, correct. Okay, so that's great. You've identified them. They're lying, floating around in the Bowman space. And they, of course, you can't see the processes, but that's what's happening there. Okay, so very nice, normal looking glomerulus. Now we will see our special stains, that is the PAS. I know it's PAS because all my basement membranes and the Bowman's capsule are highlighted. And an absolutely normal looking glomerulus, okay? Now I want you to also note what's happening in the tubules here. This is telling us that there's something wrong with this kidney. It's obviously there's something wrong because these tubules are filled with protein resorption droplets, which are these PAS positive droplets. Okay, so this is that evidence that these glomeruli may look normal, but they are not functioning normally. They're allowing all this protein to leave, and the tubules are now absolutely overloaded. If you remember, it's the function of the proximal convoluted tubule to reabsorb whatever little bit the glomerulus let through. Now the glomerulus is letting everything through, so tubules are now overloaded, and you will see light microscopically visible protein resorption droplets in those tubules. We come to the silver, that's the Jones silver methenamine, and you will see again nice pliable loops. They are absolutely fine. And we would run an immunofluorescence, and the immunofluorescence would be absolutely negative. Okay, this is not an immune complex mediated disease in terms of what we have seen till now. There are not going to be any visible deposits. But when we come to the electron microscopy, we will see that the podocytes are not healthy. Okay, so if you remember the image of the normal, we had podocytes absolutely erect, standing there with visible slit pores. But now see here, it's effaced. It looks like it's just fallen flat, and now you have reduction in the slit pores. This is all damaged slit diaphragms. Here I can see one visible slit pore, and then I see again there's an absolute effacement. You also see microvillus transformation. So ultimately, it is only the electron microscopy which tells you that these glomeruli are absolutely unhealthy because they're showing podocyte effacement. That's the way we would diagnose a minimal change disease. Now let's look at FSGS. How does FSGS look? From the name, it suggests that the disease is focal, the disease is segmental, and that the glomeruli are sclerosing, right? So just to recapitulate, focal means some of the glomeruli, less than 50%. Segmental means within that glomerulus, part of the glomerulus, less than 50%. And we will see sclerosis. So sclerosis basically means laying down of collagen. So that bit or segment of the capillaries is now kind of collapsed on itself. There's been increased collagenization of that area, right? And the trick here is to remember that all FSGSs will always be peripherally located, right? Because the problem is loss of podocytes at the periphery, so your sclerosis will always be in the periphery. So if somebody is confused now with a KW, could this be a KW? Why can this not be a KW lesion? Let's say this patient has some history of diabetes also, and I get this glomerulus. Why do I think that this is not a Kimmel-Steele-Wilson nodule? Can anybody unmute and tell me? It looks like that, right?
So there
Solid
is
hair.
no aneurysm in the capillaries.
There is no aneurysm formation in the capillary. Absolutely. Okay. So that is a mesangial nodule surrounded by patent and aneurysmally dilated capillary loops. Okay. So now do you see the difference? This is a peripherally located sclerotic segment. You will actually see some of these cells crowning it. I'll show it to you in another slide. Now, along with the sclerosis, which is collagen, you will also have accumulation
Also
of plasma.
smaller and multiple, right?
Smaller and
Compared multiple smaller, circumscribed things. This was like half of the glomeruli involved, something like that.
you're right. That diabetes can look it can have a very variable morphology, but this does not look like a classic KW for you. That's as far as we need to get. Okay. Now we'll confuse you a little more because sometimes you can have accumulation of plasma proteins in these sclerotic segments. So just like there's laying down of collagen, you will see accumulation of these plasma proteins, which will look like hyaline. Okay. And you will say, well, again, you remember your insudative lesions of diabetes? What are the insudative lesions of diabetes, which are again basically plasma protein accumulations? Anybody wants to unmute? Do we have any PGs?
Fibrin caps.
Yes, very good. And capsular drops.
Capsule.
So you need to know KW, you need to know fibrin caps and capsular drops. But ये वो सब कुछ नहीं है. This is not a diabetic patient. This is just segmental sclerosis with accumulation of plasma proteins giving hyalinosis. So some people used to call it focal and segmental glomerulosclerosis and hyalinosis. Okay, so basically scar formation because of loss of podocytes.
But this should be considered if given a history of diabetes. It still looks similar.
If we history of diabetes. we would not expect you to be able to make out the minor differences, but there are differences. For example, if a patient has got KW lesions, if this was a KW, I would also see a lot of mesangial matrix expansion. I would see capillary wall thickening on a PAS as well. Okay, so those are the subtle points on histology. But the clincher for an FSGS, if you're confusing it with a KW, let me show you on this image. Okay, peripherally located, no patent capillaries, everything has just mangled up within that sclerotic collagenized segment. It will look PAS positive, that's fine, okay, because there's a lot of now matrix which is coming along with the collagenization. But the trick is peripherally located, there's nothing patent around it. Also, when I look at the rest of the glomerulus, I'm not seeing the usual mesangial matrix expansion of a diabetes, right? What you will also see very commonly is this crown of cells around the sclerotic segment. And these cells are very important and they're very interesting. And we kind of call them podocytes. We say, that they are these podocytes which have come and crowned the segmental sclerosis. But you think about the pathogenesis. In FSGS, there is loss of podocytes. So what are these cells? So let's see. We'll discuss that. This is on the Jones-Silver methenamine again. Glomerulus looks absolutely fine here. Here I'm seeing it's stuck. It's sclerotic. There is accumulation of plasma proteins which are silver negative. So this is segmental sclerosis with hyalinosis. What does it look like on Mason's trichrome? Again, it's very sclerotic. There's collagen, which is blue. And at one other edge, another segment is actually just showing you a little bit of hyaline there. Okay. Now, when I go into the electron microscopy of a patient of this primary sort of FSGS presenting with nephrotic syndrome, it will be absolutely same as minimal change disease. Okay. When I look at the electron microscopy of a glomerulus, and we try to stay away from the sclerosed glomeruli. We want to see glomeruli which are relatively normal and on histology. Okay. So what we will see is again podocyte effacement. So it's nearly ditto. So if somebody asks you, can you differentiate minimal change disease from a primary FSGS on EM? We can't. The EM just confirms that there is podocyte injury. And this podocyte injury is very widespread, just like we saw in the minimal change disease. Okay. Again, remember, I am talking about primary podocytic injuries right now. So minimal change and primary FSGS would present as nephrotic syndrome. Steroid responsiveness would be different, of course. We've seen the difference in histology. IF, we'll talk about. FSGS can have some non-specific entrapments, but EM will be the same.
Does this suggest that, like, clinically one transforms into the other, like minimal change?
That's a very, very good question, because that debate is still on. Okay, and from the clinical side also, we'll get a lot of questions like this. So, for example, let's say you had a child who was not responding to steroids, therefore got a biopsy. And on the first biopsy, you called that child minimal change disease because you didn't see anything, right? Now tell me, the kidney biopsy is only what fraction of the kidney? It's tiny, it's minute. The kidney is much larger. The biopsy we get is much smaller, right? So there is first of all a question of sampling. Maybe there's an FSGS and I've not picked it up. Anyway, 3-4 years later, the child gets another biopsy. Usme ab FSGS hai. So what does that mean? So the debate is still out there. Some people consider this as a spectrum, that initially the podocyte hit gives a minimal change morphology. If there's continuing podocyte loss, it will result in an FSGS, right?
But minimal change is reversible with steroids, or if it's responsive to steroid, that is, it is reversible, right? Is FSGS reversible? With
FSGS,
whatever sensitive on. I mean, I don't mean steroids. Whatever drugs it's sensitive on, whatever drug it remits, is it reversible, the damage that occurs in the podocytes or the whatever sclerosis
No.
occurred?
So the answer on histology is, once that sclerotic segment has developed, that is irreversible. It's like a scar. Think about it like a scar. that glomerulus will always have that scar. That glomerulus, once it has lost its podocytes and a segmental sclerosis has developed, that glomerulus will always have that scar. Okay, so these patients usually will not be steroid responsive, but they will be given other drugs like calcineurin inhibitors, which will protect the rest of the podocytes, right? And you will learn more about these mechanisms in later semesters. But they will bring those podocytes, jitne bache podocytes hain, it will get them to work. So patients will remit clinically. Do you understand? There's a difference between remitting clinically and remitting on histology. So that FSGS lesion will never go away, but with calcineurin inhibitors in a steroid-resistant patient, you will be able to protect the rest of the podocytes and patients will remit, their proteinuria will settle. Okay? Is that clear? Am I making sense?
Right. Okay.
And the other very important concept to understand is the 80 to 90% of children of nephrotic syndrome who are steroid sensitive, they're never going to get biopsied. Okay? So they're all presumed minimal change. Okay? And the bachas who do get biopsied because they're steroid resistant, even if they show minimal change, there might be an FSGS there. So for you, the concept, that is why everybody's moving to the concept of primary podocytopathy. It doesn't matter what I see on the biopsy. I need to document the podocytopathy, and then the importance is of steroid responsiveness hai ki nahi, ultimately, right? So if any of you become physicians and nephrologists, so you're not going to be calling up your pathologist and said, "Abhi aapne minimal change bola, ab aap FSGS bol rahe ho." Okay, because it doesn't matter. It's all part of a primary podocytopathy. Okay, so we're going to move on and now try to really understand what happens in that FSGS with this pictorial. So let me show you what's happening here. So this is on the left side is what is relatively normal, right? So you've got your podocytes, you've got your upright foot processes, and you've got intact slit pores. What happens when there is some form of podocyte injury? And let's talk about primary hits. We'll talk about what the primary hits could be. But when that podocyte gets injured, can you see what's happening to the right? You now have podocytes will kind of leave a bare GBM. Okay, there'll be loss of foot processes. Initially, they will efface and then they will just fall off. They're gone if the injury is severe enough or prolonged enough. So what that results in is a bare GBM. Now, this bare GBM, which no longer has the podocytic protection or cover, is now going to go and adhere to the parietal epithelial cells or the Bowman's capsule towards the periphery. Okay. So again, to the left, you've got a healthy situation, and then you've got podocyte loss. Here, they've just fallen off. And what happens when they fall off is the current hypothesis is that these parietal epithelial cells have a stem cell component in there, and they will try to produce cells which will work like podocytes. Okay, so there may be these progenitor parietal stem cell origin cells which will migrate, and they will try and do a repair here. Okay, now if that repair doesn't work, what will happen is there will be scar formation. Okay, so what you see around the scar, those cells, those big cells which were surrounding the scar, they can't be podocytes because podocytes have fallen off, which is why the scar has formed. But those cells crowning the FSGS are likely to be these cells which are trying to repair. Okay, so we consider them, we call them podocytes crowning the segmental sclerosis, but they're actually podocyte-like cells which have come from this progenitor layer to try and heal that glomerulus. Okay. So FSGS has been looked at in many ways, and the older ways in which it was looked at was in terms of the position of the segmental sclerosis. And let me just take you through the important points for you to remember. If the segmental sclerosis was found to be more perihilar, okay, they found that these perihilar FSGS corresponded more to a secondary sort of FSGS, secondary to hypertension. We'll talk about this. Okay, so perihilar FSGS corresponds to hypertensive related secondary FSGS. On the other hand, if they found an FSGS in the tip location, which is at the tubular pole, this is called the tip location. This corresponded to a very minimal change like primary podocytopathy, steroid responsive. That's the second one you should know. The collapsing phenotype, some people like to separate it out from FSGS, other people put it within the FSGS. The collapsing phenotype is the worst to have. Of all the patterns of FSGS, the collapsing phenotype is the worst. These patients do very badly. They have heavy proteinurias and bad dysfunctions of the kidney. Cellular, that's the fourth in the Columbia classification, is actually considered to be just an early phase of FSGS where you still see a lot of macrophages and things, but ultimately they will turn into good sclerosis. Okay? So for you to remember, if there is a collapsing variant, it's worse prognosis. If there is a tip variant, it behaves nearly like a minimal change disease, very high chance of remission, especially with steroids, and you'll see less further histological damage. Okay. So a closer look at collapsing. We've talked about what happens. What we think that happens is that the primary podocytic hit causes the podocytes to be thrown back into the cell cycle as they de-differentiate and they proliferate and they will push the loops in. This is from a more recent case. Can you see how the podocytes have filled up the Bowman space? So does this lesion remind you of any other thing that you've seen till now? What else fills up the Bowman space? Anybody?
Eccentric.
Descents. Yes, absolutely. Okay. So for the renal pathologist, figuring out crescent versus collapse, we have our ways to do it. But for your level, yes, the crescent will also fill up the Bowman space. That's why these patients behave very much like an RPRF or rapidly progressive. Anything which fills up the Bowman space, right? There's no possibility of urine going through. These patients will be oliguric and uric. And along with that, patients of collapsing will also have very, very heavy proteinuria. So it's the worst type of podocyte damage to have. Okay. Tip variant is just an FSGS. By location is at the tubular pole. If you can't see an open tubule, doesn't matter. You just go opposite to hilum is what we would consider to be the tubular pole. Okay. So if you look at this Kaplan-Meier, you'll see it. The tip lesions behave the best. The collapsing behave the worst. And if you can't classify into any of these, you just call it NOS. So the predominant type of FSGS is actually NOS, not otherwise specified. FSGS, NOS. Okay. Now, the third, so out of the four initial primary podocytopathic injuries, I have shown you minimal change, I've shown you FSGS, and I've shown you collapsing. What I've not shown you till now is diffuse mesangial sclerosis. This is what it looks like. You see mesangial sclerosis, and you will see a lot of, you will see some level of crowning with the podocytes. Okay. So why is it different from FSGS? Here, the sclerosis is completely mesangial. Okay, it is not peripheral with normal capillary loops around it like a regular FSGS. This is called diffuse mesangial sclerosis. It's a global mesangial sclerosis. It shows some sort of crown of visceral epithelial cells, but they are not as hyperplastic as a collapsing. Okay. So now the question is, what hits those podocytes, right? I'm talking to you about primary podocytopathies. What are the possible hits to the podocytes?
Mesangial sclerosis is like a pattern found in certain etiologies, or it's like a disease of sorts?
No, it's a pattern of podocytopathy, and it has its associations, and I will talk to you about that. It has a major genetic association. Okay, so I'm just getting to that. So what I'm trying to show you here now is what are the things that can primarily hit the podocytes. Okay. Now, in a small percentage of patients, the cause is a single gene defect, which is a monogenic cause. Now, these monogenic causes are going to be, of course, more common in childhood, very early onset FSGS. And as you can imagine, where would the mutations be to cause that kind of nephrotic syndrome? They would be predominantly in the SLIT4 proteins or in the connecting proteins into the podocyte. So what happens if a child has a nephrin mutation, which is an NPHS1 mutation? It results in a congenital nephrotic syndrome. It is called congenital nephrotic syndrome of Finnish type. What does congenital nephrotic syndrome mean? This means that the child will be nephrotic from either in utero nephrotic or up to 3 months of birth. Okay. This is if nephrin is mutated, there is no hope of any sort of um, remission or anything like that. These patients are going to be very, very heavily proteinuric because nephrin is the core protein in this slit diaphragm. The next protein which nephrin is connected to is podocin. NPHS2 encodes for podocin. Podocin mutations are described in little later childhood FSGS. It could be infantile or early childhood FSGS. I should not say FSGS, I should say nephrotic syndrome. It doesn't matter what the histology looks like. Okay, so in early nephrotic syndrome. Now, the WT1 is an important transcription factor in the podocyte, and if it is mutated, then it results in the histology which we have seen as diffuse mesangial sclerosis, right? So what would our approach be? Let's say I get a child very early, 6 months of age with nephrotic syndrome. If I get a biopsy from that child, anyway, I suspect at 6 months of age, if there is a nephrotic syndrome so early on, I would suspect that there may be a monogenic cause. These children would actually now just go for genetic testing. We wouldn't even biopsy them. We'd never see that biopsy. Let's say the child did get biopsied and I saw a DMS. I am now very, very strongly suspecting a genetic cause. Okay. So this DMS pattern, which is a evidence of podocytic injury, and we saw that in the first slide when I talked about podocytopathy, and it correlates very, very well with genetic causes. There are 2-3 more genes. I don't want to get into the details, but if you can remember, WT1 is associated with diffuse mesangial sclerosis. Now, you've heard about WT1 in your general path. Can you tell me what are the syndromes associated with WT1 mutations? Anybody?
The WIMS tumor.
Very good. What's the name of the syndrome?
We've got something like the Vaga syndrome.
Vagar syndrome, you have the Dennis-Drash syndrome, right? So these are all WT1 associated syndromes. Now, what about adults with nephrotic syndrome? Monogenic causes become very uncommon in this age group. You can remember that there is this gene, the ApoL1, which is now a very important gene. This corresponds to a collapsing histology in adults. Okay. And it's not found in Indians, but it's in African Americans, which show an ApoL1 mutation. Okay.
Would a biopsy ever change therapy? As in, like, if we get a biopsy for a 6-month-old child and we suspect DMS, would we like skip the steroid trial or something?
Yeah, very, very good question. So let's say you got a 6-month-old biopsy. Most likely they would have already tried steroids. Try kar liya hoga, nahi chala hoga. So we will assume that it's a steroid-resistant child. And of course, when I see the DMS morphology, I will call the nephrologist and say, well, there is no chance that this child is going to respond to therapy at all. Correct? Because you have a mutation. So what is done for these children? They have to wait for a transplant if they survive it. But there would be very poor outcomes in children who are born with these mutations resulting in nephrotic syndrome. Okay.
So on the other hand, like if we clinically prove that the child is unresponsive to steroids and then get the biopsy, which as you said is like common after clinically proven steroid resistance biopsy, and would something in the biopsy let us not give CNI or let us try steroids more? As in, would the biopsy result change our action of getting CNIs after steroid resistance has been proved?
Yes, absolutely. See, why? So if I see a morphology which would correlate with a genetic cause, okay? So monogenic causes may you can try CNI. There are some studies which say that even if there is a genetic cause, if you try a CNI, it does protect the podocyte to some extent, but it's not going to work very well, obviously. Okay, because you have a problem at a genetic level in that kidney. Do you understand? When we
So like transplant is the only solution for if the genetic thing is suspected. And we
yes,
don't do the sequencing first, we do the histology first.
yeah, I mean, if I tell you current practice, if you get a 6-month-old with nephrotic syndrome, they may try a trial of steroids. The moment the child is not responding, they will immediately send for a whole exome sequencing or a clinical exome sequencing and get a genetic diagnosis. Okay. In some centers, of course, this may not be possible. You'd get a biopsy. If you see anything on the biopsy like a DMS, you still need genetic confirmation, which would be great. Even if you can't get a genetic confirmation, DMS is it's like equal to genetic cause of podocytopathy. You do not see DMS otherwise. It's always a genetic cause. Okay. Having said that, the other genetic causes, like I talked to you about nephrin podosin, what do they look like? They could look like minimal change or FSGS, right? So it will be a clinico-pathological correlation of how strongly you feel that this patient has a genetic cause. And in terms of therapy options, they'll try steroid, then they'll try CNI, and then they'll say, okay, nothing is working. Put the patient up for a transplant if the child survives. You know that there are a lot of complications of nephrotic syndrome. So it's a poor prognostic situation if you have a monogenic cause of nephrotic syndrome. Okay.
Right. Thanks. Okay.
Now, the monogenic causes are a relatively small percentage. If I look at proportion, of course, if I have a congenital onset or a very early infantile onset within 1 year of age, my chances of it being a genetic cause are much higher. But the usual age of presentation, if I talk about a childhood nephrotic syndrome, is around 4-5 years of age up to maybe 8 years of age. That is the usual age group in which this disease happens. So what is the cause there? Frankly, we don't know. Okay, we suspect that there are immunological and soluble factors. I think Dr. Shometa also touched upon this yesterday, that there are alterations in T cell subsets and cytokine profile. There's some role of B cells. And there was one marker which came out, which was called SUPAR, which is soluble urokinase plasminogen activation receptor. But SUPAR has also not it's not kind of survived as a biomarker or as a causative agent for this injury to the podocytes. Okay, so a lot of studies have said no, it's nothing. It's just a byproduct of podocyte injury. It's not the cause of podocyte injury. What is the evidence that this happens? There's a lot of anecdotal evidence, and I think this is a major gap in nephrotic syndrome right now. We still don't know that those 90% of children who got minimal change, unko kya hua? Why did they get nephrotic syndrome? We just know that they are steroid responsive. That's your number one anecdotal evidence that there is some sort of immunological issue, because when you immunosuppress them with steroids, they get okay, right? The podocytes come back. For B cell role, some patients who do not respond. Oh, and the other thing is calcineurin inhibitors are a T cell inhibitory drug. So those who don't respond to steroids, when you give them calcineurin inhibitors, they respond. Maybe there's a T cell role. Those who don't respond to calcineurin inhibitors also are given rituximab, which is monoclonal anti-CD20. Maybe there's a role of B cells. Children of nephrotic syndrome, when they get a viral upper respiratory tract infection, they relapse. So they may be completely in remission, but they get a viral upper respiratory tract infection and they will come back with proteinuria. So this is evidence that maybe that viral infection and the immune response to it also affects the podocytes. The other major anecdotal evidence is recurrence post-transplant, right? So children who have had proteinuric illness and they have received a transplant, some of them will relapse within 10 days of that transplant. And if you did an EM, their podocytes would be completely flat all over again. Okay. So these are the anecdotal evidences that there is something in the circulation, whether it's a soluble factor or it's T cells, B cells, which are have some problem with them in the cytokine profile that they release, is what is hitting the podocytes. We don't know what it is. All we know is if I give steroids, there's a 90% chance or 80 to 90% chance the child will be fine. If they're not responsive to steroids, I give them calcineurin inhibitors, 80 to 90% of them will remit. Okay. So it's still very anecdotal, empirical therapy. Now, the third thing which can hit the podocytes, for which you can actually do something, are viral infections. They can directly infect podocytes. For example, HIV, HCV, and parvovirus B19. In these patients, sometimes you will get a collapsing phenotype, not all of the times, but you may get a collapsing phenotype because there is evidence that HIV directly infects the podocytes and puts them back into the cell cycle. Okay. Another viral infection is COVID. So there are reports now of COVID also causing a collapsing pattern. Okay, but it's still, not proven. And then there's certain drugs which can also directly damage podocytes. So like lithium, interferon, bisphosphonate, sirolimus. So again, these are the rarer causes. Let me tell you that the bulk of childhood nephrotic syndrome really is this. The thing that we don't know what it is. We have no idea why this is happening, but this is the bulk of nephrotic syndrome in any clinical setting. So now briefly about what we are talking about when we say secondary podocyte injury. So what I mean when I say secondary podocyte injury is that there's something else happening in that glomerulus. And we know that all the parts of the glomerulus are so kind of interdependent that when anything else is happening to the glomerulus, the podocytes are also getting injured secondarily. So what are the other glomerular diseases? Number one here is membranous nephropathy. I was thinking whether I should put this in primary or not, because now we know what is happening in membranous nephropathy. We know that there are immune complexes which are going and depositing on the subepithelial side, and they're responsible for remodeling that capillary wall and causing proteinuria. But there is some form of a direct podocyte hit because the immune complexes are directed against podocytic antigens, right? Which is the most common podocytic antigen, which is now described to result in membranous. Can anybody unmute?
Phospholipase A2 receptor M type.
Yes, absolutely. Okay. So PLA2R is a podocytic antigen. It's responsible for 70%. Anti-PLA2R antibodies have been found in 70% of patients of membranous. So that anti-PLA2R is going, it hits the podocytes also, it forms immune complexes also, which go and deposit on the subepithelial side. Okay. Then MPGN. Even in MPGN, if you do the EM, you will see podocyte effacement. Although, of course, there will be a lot of deposits, which could be subendothelial, intramembranous, etc. IgA nephropathy. And I put an etc. there because all types of glomerular diseases ultimately will result in some level of secondary podocyte injury. Now, within these glomerular diseases, it is the membranous nephropathy, which is the one which will result in a frank nephrotic syndrome. We understand that it is really kind of an autoimmune podocytic disease, right? But the rest of these, they will not show you usually nephrotic syndrome. So an MPGN we know will show predominantly a nephritic picture, will show you some proteinuria, not usually more than 3.5 grams. Similarly with IgA nephropathy. Can they? Yes, they can. Sometimes they do. You can get a nephrotic presentation with everything there. But by and large, if I talk about frank nephrotic syndrome among these, it's the membranous. Okay. Now, systemic diseases, of course, yes, they will also cause secondary podocyte injury. So we've seen amyloidosis. We've seen that lupus nephritis can cause podocytic injury. And when it causes a class 5 pattern, you may get a nephrotic syndrome. Even diabetic nephropathy can cause significant podocyte injury. Okay. Now, there are other systemic conditions, for example, long-standing hypertension, obesity, and nephron loss. I want you to remember these three things together because these put pressure on glomeruli and cause this adaptive change resulting in secondary FSGS. What do I mean here? When you have a long-standing hypertension or if there's obesity or there is nephron loss, there's a lot of pressure on the glomeruli. That pressure on the glomeruli makes them much larger. They become very big. Let me take you back to that image right here. Okay. So, for example, if a patient has hypertension or obesity or there is nephron loss, like they had a cancer in one kidney, wo kidney nikal gayi. Now, all the pressure is only on one kidney. Okay, so you have half the number of nephrons that you would usually have. So, what does that result in? There's a lot of pressure on these glomeruli. And with that pressure, can you see here? This was actually picked out as a hypertension case. Increased pressure from intravascular, the glomeruli become larger. The podocytes can no longer cover that capillary wall so well. And this is called an adaptive. So they try to adapt, they become larger, they will try and keep covering, and they won't be able to do it. And then you will again get bare GBM, and then you will again get FSGS. Okay. This is known as secondary or adaptive FSGS. This happens in a very different way than the primary FSGS that I've spoken to you up till now, which you see in children. Okay, it is not a sudden hit with massive proteinuria like I talked to you about in the primary podocytopathy. It's a very slow, adaptive, dheere glomeruli are becoming bigger. Very slowly, the podocytes are unable to deal with the glomerulomegaly. So it results in results in a very different picture. You may have slowly progressive proteinuria. It may reach more than 3.5 grams, but it won't be associated with the syndrome. So there won't be hypoalbuminemia. The liver has been given enough time to bring the albumin, to compensate on the albumin loss. Much more slowly progressive. But what would it look like to us on the biopsy? It will look like an FSGS. Okay. So that's why this FSGS concept has absolutely changed now. If I give an FSGS diagnosis to a child with frank nephrotic syndrome, or if I give an FSGS diagnosis to an adult with long-standing hypertension, they mean two absolutely different things. Okay. If I try to treat this patient of long-standing hypertension with adaptive FSGS with steroids, you think anything will happen? Who would like to unmute and tell me?
Probably treating the underlying cause would be better.
Absolutely right. Correct. Okay. So I can stamp them FSGS, and a physician who doesn't understand what we're talking about, or if we've not had a discussion with the physician, and the physician just says, okay, it's FSGS, I am giving the patient steroids. It will have no effect, A. B, it could be worse because, for example, let's say this patient has obese and metabolic syndrome, and I'm pumping him with steroids. He's going to develop diabetes and various other complications. Okay. So I want the crux of this discussion is that the FSGS is a pattern of injury. FSGS indicates podocytes have fallen off, there is loss, and you've understood that bare GBM induces sclerosis. Okay, and different cells try to come in and try and repair. But the main thing to understand is what has caused the FSGS, right? Is it a primary podocytopathic hit resulting in a frank nephrotic syndrome, where either I have an immunological cause or a monogenic cause or a viral cause, direct hit to the podocyte, sudden nephrotic, or is it a slowly progressive adaptive FSGS? Okay, so I hope that concept is very clear about how we look now at primary podocyte injuries, which correlate with a frank nephrotic syndrome versus secondary podocytic injuries, which don't usually correlate with a frank nephrotic syndrome. Okay, I think I should get membranous out of this list actually now. Okay, I think this is my last slide. This is just to show you that we look at it age-wise, right? If it's an infancy childhood nephrotic, I think that it could be a mutation, more likely. As we go into older age, can you see the causes of proteinuria? It becomes obesity, diabetes, nephron loss. And then, infections and drugs could, of course, be across all age groups. Okay, one or two questions? Yes, let me call out somebody now. Shashwat Kumar. Can you unmute? Shubham Maurya.
Yes, ma'am.
Yes, Shubham. This is a urinary sediment from a child with nephrotic syndrome. Can you tell me what you can see here?
Ma'am, some crystalline structure, maybe protein.
Protein. Do we see protein in a sediment? दिखता है क्या हमें protein?
No, ma'am, some crystalline structure.
This could be fat droplets because lipiduria is a common feature of nephrotic syndrome.
Okay, so these are basically lipid droplets or fat bodies, and this may be a tubular epithelial cell which is full of them, or they can even just appear just like that. They're fat globules. And you're right, because lipiduria is a part of nephrotic syndrome. That is maybe the only thing you would see on a very bland sediment over as pachika. You don't expect to see RBCs or casts or anything like that, right? So this may be the only positive finding in a child with nephrotic syndrome. And protein we don't see. We estimate. We have different methods to do that, but you will not see protein when you look at a sediment. Okay, great. Any other microscopy variety that I can use to highlight this? और क्या कर सकते हैं? So if you polarize this, what will it look like? दिखाया था हमने.
Those oval bodies with Maltese cross appearance.
Cross. Okay, under polarized light, you will see a Maltese cross. Okay. I think I have one more question. Yes. I'd like all of you to read this question. It's a discussion sort of thing. What difference did you perceive in the glomerular histology between cases presenting as nephritic syndrome and those presenting as nephrotic syndrome? Who would like to unmute and answer this? You've seen so many images now, right? So many pictures of glomeruli. And you had common causes of nephritic, and now you've seen some common causes of nephrotic. What do you think is the difference in the glomerular histology?
Nephrotic histology is a more subtle one, with some of them even visible only on electron microscopy, or are secondary changes to something that is not generally visible on a light microscopy picture. Whereas nephritic syndrome usually involves inflammatory deposits. It usually can progress to a crescentric pattern, and the histology is much more evident, so to speak, with dense deposits as well, which are more visible than in classic nephrotic histologies.
Yes, I think you're there. I think you've understood. So this was basically a question to see if you've understood in all the talks we've had till now, if you've seen those images, right? So nephritic syndrome, it's nephritic inflammatory, right? So those glomeruli will show more proliferation. There's a lot of inflammation there. You can, rightly said that proliferation could be a crescentic type proliferation. They look very proliferative. Whereas if you look at the nephrotic syndrome condition, specifically MCD-FSGS, you don't see that sort of proliferation. It's not an inflammatory condition, right? It's usually a primary podocytic hit. Okay. Of course, somebody could say, but collapsing with proliferation dikhta hai, that's fine. In a collapsing glomerulopathy, you see a lot of podocytic proliferation. Okay, great. So that's it. What's next is, I think we move on to tubulointerstitial. We'll talk about vascular and a lot of developmental conditions in the kidney in the next 1 or 2 weeks. Okay, any other doubts? Anything anybody wants to ask? Yes.
Ma'am, I had a doubt. Ma'am, like the regimen you told about that when the child presents with nephrotic syndrome starting on steroids, if that is not working, then we start CNI or exome sequencing, all that. Ma'am, what is up to what age of child would be practice this regimen?
Okay, so children, as per AIIMS, is up to 14 years of age. Okay. When a child presents to the pediatric nephrologist with significant proteinuria or nephrotic syndrome, they will first do a clinical assessment and investigations. Okay? Clinical assessment में nephrotic इन्होंने देख लिया, edema है, all of that is seen. And then they will do lab investigations where they will specifically check sediment, they will check for hematuria, they will check complement levels, serum C3, C4. Okay? And then they will decide that, okay, this child is fitting into classic childhood nephrotic syndrome. That clinical picture is usually a 5-year-old presented with sudden onset anasarca, with bland urinary sediments, and everything else is normal. There's no hypocomplementemia or anything like that. That is your classical childhood nephrotic syndrome. These are the children who will immediately be put on a trial of steroids. Okay? Having said that, the moment you go to older age groups, a 10-year-old, an 11-year-old, a 13-year-old who presents with nephrotic syndrome, that's a red flag. This is not the usual age for a standard steroid responsive nephrotic syndrome. There might be a lot of other things. Maybe there's an MPGN, maybe there's an IgA nephropathy, maybe it's membranous. Okay? So this is what I would say. Very, very early onset nephrotic syndrome, they might try a trial of steroids and they would immediately go for genetics after that. If it is within a year, it makes sense to do genetics. Nahi karna to biopsy kar lo, which may or may not help. Correct? Very early onset nephrotic syndromes. Uske baad, from 1 year to maybe, I think, 7-8 years of age, and I'm not the right person to tell you this, the pediatric nephrologist will be talking to you about it in later semesters. But this is from our experience, this is the usual age in which you have the classic childhood nephrotic syndrome. Give them a trial of steroids, 80% sensitive nikal aayenge. Okay? Jo nahi sensitive hue, do a biopsy. Standard. This is the standard. And in the older patients, beyond 8 years, so from 8 to 14 years of age, you have to be very careful of other causes. That is not the usual age for a classic childhood nephrotic syndrome. Okay?
So, ma'am, when
will be given a trial of steroids.
Yes, ma'am.
What I want to say is that age group will also be given a trial of steroids. They may, the moment that they will likely be resistant. They will not respond to steroids most likely. That will trigger a biopsy. And in these age groups, the chances of finding other things go up. Okay, so you see a membranous or an MPGN or an IgA. Okay? Anji, or batao, Swapnil.
Thank you, ma'am.
So you see that especially in renal pathology, you will see that discussion between the pathologist and the clinician is paramount. I think Dr. Adarsh also mentioned this yesterday. Kidney biopsy reporting does not happen unless we have significant clinical detail. We will go back to the nephrologist and talk to them. So that discussion is a constant within in kidney pathology, especially, I feel. Okay. So I think this is a good opportunity. You have a weekend now to kind of consolidate your glomerular diseases understanding. I'd be happy to start before starting tubular interstitial. We can have a 10-minute Q&A. If there are any issues that you've felt as you've gone through whatever study material, then we can kind of close glomerular diseases before we move on to the next, because otherwise there's a lot in tubular interstitial also. Okay? Okay, thank you. Anjana, if you're there, तो इनका attendance का देख लो.
Yes, ma'am.
I'll leave the meeting now. Thank you.